Good morning, everybody, and welcome to this meeting in public of the board of NHS England. And I extend, as always, a particularly warm welcome to those members of the public who have joined us. I apologise for the length of the room, but I hope you'll be in a position to observe and hear what goes on this morning. We've got a very full agenda of some items of great importance to the future of the NHS and of patients and public in England. A few words by way of introduction, first of all. The formal body, NHS England, which was previously known as the NHS Commissioning Board, took on its full array of responsibilities on the 1st of April this year. Up until then, we were in pretty much set-up mode. At the end of March, our staffing complement was not much more than 100 full-time equivalents. From the 1st of April, it was about 6,500. So in the time since then, we have assumed an important array of responsibilities. We have taken on board new staff, new premises, new IT, and we have been establishing ourselves. That is in the course of just 15 weeks now of full operation. Our responsibilities are, in general terms, to ensure that every pound that is invested in the NHS in England delivers maximum value for patients in terms of the quality and the safety of the healthcare that we provide. We operate in close relationship with the Health Secretary, but also with the other arm's-length bodies, such as Public Health England, Health Education England, NICE and Monitor and CQC. But we have a particular responsibility for ensuring that not only do we meet the needs of the population today, but also tomorrow. And in the course of the meeting this morning, we will refer to the call to action that we launched just last week as a way of trying to think about the needs of the population over the next decade, where the capacity of the economy to continue to invest in the NHS as it has historically is going to be very severely constrained. We need new ways of providing services and new ways of empowering patients and new ways of conceiving of a comprehensive health service fit for the 21st century under those conditions. We've established from the start a commitment to a new way of doing things, a commitment to being transparent in the way in which we operate, a commitment to ensuring that data drives our decisions and that data relating to the performance of the health service in England are made generally available, not only as a means of ensuring that we know what's going on, of tracking improvements and declines in the quality of performance, but also empowering clinicians and patients to understand how the system works and how better to ensure high quality outcomes from it. Amongst the values that we adopted from the beginning was a commitment to meeting in public. And that's why we're gathered here this morning, because we believe fundamentally that when big decisions are being taken about the investment of taxpayers' money in the health of the population, that people are entitled to know how those decisions are taken and to see those decisions being taken. I should observe two matters, though. One is that a meeting in public isn't a public meeting. In other words, we're here under your scrutiny as members of the public present, and the meeting is also being web-streamed and will be observed both live today, but also become resident on our website. So it is a meeting of observing the board actually at work. Secondly, we do business outside the formal meeting, and just to assure you of what the nature of that business, yesterday we held what we call a development meeting, and that's when the board gets together with all our executive team and non-executives and work through some really difficult strategic issues which aren't yet in a state of development where they're fit to bring to a formal board meeting, but where we're working across the board as a unitary board to get our heads around, and yesterday some particularly difficult issues around direct commissioning. In due course, that will work itself into a strategy paper. It will come to the board, and in a formal public meeting, we will debate our future strategy on that front. Secondly, after each formal public meeting of the board, we will have a private meeting, and we are concerned to ensure that the only items that go onto the private agenda are those which, by virtue of their confidentiality, cannot be discussed in public. And there is a specific reason for each of the papers coming to the private meeting because of the need to maintain commercial or personal issues of confidentiality. So I welcome everybody to the meeting this morning, and I just conclude my opening remarks by saying there's no fire drill scheduled, and should the alarm go off, colleagues will marshal us all to the appropriate refuge points. The meeting now commences formally. I have to record the apologies of one of our non-executive directors, Margaret Casely-Hayford, who, for good reason, is not able to be with us this morning. I then move on to the minutes of the last meeting of the board.
Sorry, Chairman, could I declare an interest?
I'm sorry.
In the agenda, just to declare an interest in item 13 of the agenda. I'll be withdrawing from that. My wife is the Chief Executive of Birmingham Children's Hospital.
I'm sorry, and may I ask if there are any other declarable interests of board members? No. Okay, thank you very much. May I then turn to the minutes of the meeting of the board on the 3rd of May. They've been circulated. I haven't had any comments back from members of the board. Are there any comments on the minutes? You're happy to accept them as an accurate record? Thank you. We have an action list detailing the status of the action from the previous meetings of the board, which I would ask the board to note. We're content to do that? Thank you very much. I would now like then to move on, please, to the report of the Chief Executive. We have a paper. I'll invite David Nicholson to talk to it.
Thank you. I want to talk a bit about a couple of things that are on the report, but I also want to show us a film that's been a short film that's been made, which kind of brings us up to date with some of the bigger issues on this agenda, and I think brings them to life in a way perhaps that a report doesn't always do. If you think about the time from the previous board meetings, there's been significant issues affecting the NHS that have been in the public domain. Not least of all the work that Sir Bruce has been leading on the 14 hospitals. It's worth saying that work was commissioned by the Secretary of State from Bruce personally. It wasn't an NHS England issue to take forward, but nevertheless, the staff of NHS England, particularly our regional directors, our nurse directors, our medical directors out in the field, have been playing an enormous role in working through all of that. And I have to say that although the issues raised in that report were difficult and problematic for the NHS, I think they're really important issues for us to tackle. I genuinely believe that when we look back in 2 or 3 years' time, that the events of the last few months in the NHS, particularly how important it is for us to become much more open and transparent about the issues, to make sure that people are aware of them, will be seen as a major turning point for the NHS, which enables it to renew itself to take things forward. And it's really important, I think, for us as a board, and taking particularly the point that the Chairman made earlier, is that our commitment to transparency needs to be unwavering in these circumstances. Even though it is difficult and uncomfortable and problematic, we have to really stick firm, because that is the way in which we'll be able to renew the NHS. I don't think it's probably worth just asking Bruce just to say a few words about the review, which I think is really important.
Thank you. I'm not going to comment on the content of the review, because I think that's been pretty widely reported. But when we were designing how to do this, we've attempted to set new standards in 3 areas. The first was the methodology of inspection. The second was transparency, and the third was how we provided help. So with respect to the methodology, we were very keen that the people that inspected the hospitals knew how hospitals worked. So we used senior doctors and senior nurses and senior managers to visit to visit the hospitals. But most importantly, we added in patient and public representatives and also junior doctors and junior nurses. So the end result was a team that could really get under the skin of how a hospital works pretty quickly. And we had announced visits and also unannounced visits, many of which occurred during the night. So we were pretty well able, I think, to find out what was going on. The other thing that we did was we ran focus groups with members of the public. So there were adverts in newspapers asking the public to come to these focus groups and let us know what they thought. And I can't begin to tell you how valuable the information was that came out of those groups. The second area, transparency, we assembled, I think, the most comprehensive and diverse data set that's ever been assembled for these sort of assessments. And we used that to drive key lines of inquiry to inform the teams that went into the hospitals, so that they knew where to at least focus their initial attention when they arrived. That data was made public pretty well from day one. We also published the evidence from the review teams in two forms: the written evidence, which was submitted to the chief executive, but perhaps more importantly and newer, if you like, we recorded on video the evidence as it was presented to the risk summits. And the reason I was keen to do that was that many people felt they'd put their necks on the line coming to tell us things about either the organization that they worked in or the organization in which they had been treated or were continuing to be treated. And I didn't want those people to feel that anything that they had told us had gone unrepresented. So they have an opportunity to look at those videos to reassure themselves that the evidence that they gave to the review teams has been accurately and fairly represented to the risk summits who considered the evidence. And finally, in the transparency, we've published the action plans so that everybody can see them. So in a sense, what we've tried to do by publishing all this information on NHS Choices is take the assessment away from just a few people who work for a regulator, right out to patients, the public, and those who work in the organisation, so that everybody feels that they have an opportunity to help guide the assessment and the improvement of those organisations. And then the third area is, it struck us that very often regulators or others come into a hospital, they say you need to improve this, that, or the other thing, but there's very little help forthcoming. Many of these hospitals have known that they've had difficulties, they've struggled to try and solve them in the past, and we wanted to put a mechanism in place to ensure that they got the help they needed. And that's where the risk summits, which have been devised by the National Quality Board, came in. So the evidence that had been accrued by the review teams was then presented to a risk summit, which is a group of people in a room who represent the regulators, that would be CQC and Monitor, the Trust Development Authority, Health Education England, NHS England, the local authority, and the provider. They helped develop the improvement plans for these hospitals, and it meant that everybody had skin in the game. This was not simply a problem for the provider. So all of those parties, including the clinical commissioning groups, are party to the action plans and party to helping the organisation solve the problems that they've been grappling with for some time. Now, in the process of doing this, we've uncovered some pretty uncomfortable and often unspoken truths about individual organisations, and I think about our NHS as a whole. And as a consequence of that, we've tried in an overarching report to lay out 8 simple, achievable ambitions for the NHS, which were based on our findings in these 14 hospitals, which, if applied throughout the NHS, I think could help to shift the NHS quite significantly in terms of the quality of care that's provided. That's all I'd like to say. Thank you.
I mean, I absolutely echo the things that you've said there, Bruce. And I think, as I say, people will see it as a big moment for the NHS. And it's worth pointing out that Mike Richards, who's the new Chief Inspector of Hospitals, announced either yesterday or today, I can't quite remember, that he's essentially adopting the methodology that you've set up there for the rest of CQC, using the same kind of things. And I think that's really, really positive. And I have to say that overall it's been well received by the organisations involved, in the sense, you're absolutely right, Bruce, that many of them really do need help. And that's an opportunity for them to get that. So that was one big, I think, issue for us. The second big issue since the last board meeting, of course, was the publication of the spending review. And I know it's on the agenda later, and Paul will take us through some of the detail in relation to that. The only point I would make in relation to it, that this is a significant change in the way in which resources are allocated and the way that we do things. For years now, we've been talking about integration, about bringing health and social care together. Where there are different parts of the country where people have made progress, but this shift in resource in the system, which is identified in the spending review, I think is a really sort of bold and ambitious attempt to make it a reality everywhere. But it is significant. It is not by any stretch of the imagination, a trivial act that's been made here, and will have significant impacts on both the delivery of healthcare and the delivery of social care across the country. And as I say, Paul will talk about that a bit later. So in terms of the rest of the report, can we show the video tape now, which I think sums up, where we are overall.
We had a few teething problems at the start of the NHS 111 contracts that we took on for Northamptonshire and Nottinghamshire. Taking on the 2 new contracts as part of a more national service presented a few challenges. We have had a difficult time in the last few weeks and not achieved all of the quality standards that were required, but now we are. After about 6 weeks, we managed to turn things around by intensive support and further training and recruitment, and now we have a very safe, efficient service, and we're providing a service that meets all of the national quality standards now, so we're very, very pleased.
So we're all aware that this winter we've had real problems with urgent and emergency care. The system we have is unsustainable and things have to change. So what we've done is bring together a group of doctors and nurses and patient representatives who've lived and breathed this problem, and they've come up with their ideas and they've looked at the evidence that may help us change the system. But what's going to be different is we're now asking you to help with that, to contribute, to tell us what you think, to put in your ideas so that we can redesign a system that is really sustainable and meets patients' needs.
Since the advent of the CCGs, we've had very, very close relationships, both with the managers and the doctors in the hospital. And we can have sensible discussions. So we have weekly meetings, either face-to-face or on the telephone, to predict where problems are going to be and who's going to step up to the mark and what we're going to do about them. So we're hoping to preempt the problems. And that thing that's shown itself, because where previously we were failing to meet the national target of 95% of patients seen within 4 hours, we've just met the 95% target this quarter for the first quarter of the CCG. And we're really proud of that, and the Trust should be really proud as well. The Director of Performance has got my phone number, I've got his, and if there's a problem either way, we just pick up the phone or email each other, and we'll try to sort out whatever the problem is as rapidly as we can.
One of the major scandals in the NHS, I think, is that if you are unlucky enough to fall ill and you need something done, it's been almost impossible to find out who does what. You know, what volumes of surgery are done by individual practitioners, what their outcomes are, and that's all changed now with this announcement. This is a major event in the history of the NHS. We know from cardiac surgery over the last 10 years that if you collect this data, analyse it, feed it back to clinical teams and publish it, you get massive improvements in quality. So the mortality rates in cardiac surgery now are a third of what they were 10 years ago. And now that methodology is being applied to these other specialties. That has to be good for patients. Not everybody in the profession has welcomed this initiative with open arms, but in my view it is a privilege to be working as a doctor and as a surgeon, and with that sort of privilege there are some responsibilities, and I think one of those responsibilities is to measure what you do and to demonstrate openly to the public that you're doing that to a satisfactory level. I think if you're not prepared to do that, you shouldn't be doing it at all.
Patients being able to access surgical outcome data is important. It means that they can make an informed decision about which consultants they go and see at which hospital, and that can only be a good thing.
The NHS is 65 years old. It's facing huge challenges and pressures for the future. The expectations of our patients, the demands on the service, the development of medical technology, and the financial circumstances that we find ourselves on. The call for action is to call for people to come together to think about what the NHS in the future might look like, to make their contribution, whether they are people who work in the service, who use the service, or members of the public. How can we all work together to get a compelling vision for the NHS for the next 65 years? I hope that brings it more to life, the kinds of the impact, the things that we're trying to do, and all the rest of it. And it didn't have Tim Kelsey in it, by the way. That was the other point. But I do, and it ended up in a sense on the call for action, which I think is a really important kind of rallying cry for the NHS going forward. One of the unique contributions that NHS England can make in the way that it was set up is to think beyond the short term, to think strategically about the next few years for the NHS, what it's going to look like, how we're going to take it. We're going to take it forward, unencumbered by short-term considerations. So really important that we use that opportunity to go forward. I think Bill's going to say something about the call for action.
We'll go into that on the next item on the agenda. Just before we do, if there are any questions from my colleagues to the Chief Executive? Please, Victor.
The hospital inspections, but I think I sent you a text just to say I thought you handled it really well. I thought the media interest was really handled very well indeed. I'm not sure that it was reflected in what was said in the House of Commons, but I think the way in which you handled the media was very good, and I think you should be congratulated on that.
Yeah.
I could just say, I think, two things on that. First of all, that what the Keogh review demonstrated was that you don't know how to fix a system until you know what's wrong with it. And we've been rather too accepting in the past of poor performance, and to be able to discover what doesn't work is critically important for the future. But secondly, I think, was the innovative character of the way in which you went about it, Bruce, and the as you stressed to us this morning, the involvement, particularly, I think, of junior doctors and nurses, the people who really are at the coalface, who understand what's happening, and to empower them to come forward and speak about it. I think that was a bold step forward, and one which we hope will continue. So, again, on behalf of the board, thank you very much for what we see as a vital next step in the development of the NHS. I have Kieran.
Just linking the transparency agenda, and the approach through the review into commissioning. And I guess the challenge for us is, how do we commission for transparency? So are we in a position to be able to say part of the terms of trade is that we expect people to be transparent, and that's the way it's going to be in the future, and in 5 years' time this kind of thing will be an expectation, but it might also be contractual?
Absolutely, but I do think here we start with our own activities. So the direct commissioning, all of that sort of thing needs to be exemplar in terms of transparent commissioning. And I do think you're absolutely right. We need to back that up with a slightly harder edge contractual terms and incentives in the system to enable that to happen. That's absolutely right.
Good. Well, thank you very much, Dave.